too much about technical issues. Um, we're going back and we're examining a couple of things related to the legacy that you all have as neurobiologists. So all of you are aware of all of the great neuroscience that's gone on before you, and you are at the sort of zenith of all of the different techniques, all of the different knowledge that's available for you because of the different Nobel laureates. And we've talked about a number of them right now, and we're going to continue talking about more of them as we go on throughout the rest of this course. Today, though, I'm actually going to tell you a story about someone or some individuals that are a little bit different. And a lot of times we have this sort of legacy that's positive, and in some instances we actually have a legacy that's a little bit more negative. And today I'm actually going to be telling you about the Dark Nobel Prize in neuroscience. And so we do have sort of an individual that we sort of keep in the closet, sort of as a one of those weird uncles that you really don't want to run into on those family reunions. And we have one of those individuals as well. And their story actually doesn't begin until 1949, but I'm going to tell you a little bit more about the antecedents of what they actually thought up. I guess we're still going to have some technical issues along the way. Who are these individuals? Any ideas? Yes. Sorry, is that who? Is that? Well, okay, you cheated. All right, that's okay. Yeah, no, that's good. You should always be using whatever resources are available to you. So that's good. I think that if you're not aware of these individuals, again, apologies on this. It looks like we do have some technical issues going on. This is Bernard Holmes, and this is Henry Cotton. You may not be aware of these individuals. And in the 19th century, these individuals were actually the best scientists and the best physicians and the best psychiatrists of their day. And they actually had some really interesting ideas. So both individuals actually developed a field, and you don't have to worry about taking down notes. It's really to give you an idea of why we're talking about the things that we're talking about. These individuals actually started a branch of neuroscience called psychosurgery. Nowadays, you would call this neurosurgery. They were the forerunners of what is now classically considered neurosurgery. And both Holmes as well as Cotton actually developed a couple of really interesting ideas. But their ideas now would be considered quite crazy, or maybe they wouldn't be. So Holmes actually was a physician, and he was a physician who is actually eventually became the dean of a large university on the East Coast of the States. And one of the things that he thought was that mental health disorders were caused by an imbalance in your gut. And one of the things that he decided to do was to do surgery on his own son and to open up his bowel, cause a perforation where the bowel would be sticking out, and he would lavage it. He would clean his bowel several times a day to help him overcome his schizophrenia. Of course, that surgery wasn't very successful. His son dies, okay? But this was sort of what people were thinking at the time, that a mental health disorder was actually caused by an imbalance somewhere else in the body. It's the same idea that Henry Cotton had a little bit later on. So Henry Cotton also published a paper on a very similar topic. And what he also thought was that if, for example, you were able to manipulate the colon or manipulate different parts of your bowel, that you would be able to relieve a lot of the symptoms that are associated with different types of psychopathy, as well as different forms of mental health disorders. And again, he was primarily interested in the psychoses that accompanied major depression. So those are the antecedents. And in fact, after they published, these individuals here, and I know you all know these individuals. Who are they? No hints here on the bottom of these. Nice try though. If you have like the ability to see the next slide, you'd be able to tell me, but I don't think you do. Yes. Sorry, is that Freud? Kind of looks like Freud. No, He's actually Swiss, the person on the right. Any other ideas? Yes. Jung. No, not Jung. So these are individuals that came about in 1949. These are sort of our forerunners of a lot of the things that we're going to be talking about today. These are the winners of the Nobel Prize in Physiology and Medicine in 1949. Not that long ago, so about 60 some odd years ago, they won the Nobel Prize. And Moniz actually looked at some of the papers that were published by Cotton, and one of the things that he thought was actually really interesting was that maybe instead of operating peripherally on the gut, maybe it's a better idea if we go in and we manipulate the brain itself. And so one of the things that he developed was a technique known as a leucotomy. Most of you will have heard of a leucotomy as a lobotomy. And he was the forerunner of a surgical technique where different regions of the brain were operated on and removed. And he thought it was a good idea to remove parts of the prefrontal cortex, for example. He thought it would be excellent to help out people that had hyperkinetic disorders, people who had schizophrenia, people who had manic depression, or bipolar disorder. He thought, what a great idea it would be to go in, do surgery, remove parts of the brain, and all of those symptoms will disappear. And guess what? They did. They disappeared because they basically lost motivation. They lost a lot of their function. And this is sort of the dark history that we have. The other individual here, Walter Hess, actually is the forerunner of psychosurgery as well, or neurosurgery in a different way. And what he did, and what he won the Nobel Prize for, is exactly what we do now. So when you go in and you stick an electrode in the brain and you stimulate it and you see what sort of behavior arises, it's because of his work. He was the first individual in the 1930s to actually put in electrodes in different parts of the animal brain, and then he saw what the resulting behaviors were. And in fact, he is the individual that we'll be talking about later on today. All of the experiments that led to our understanding of neurotransmitters and how different areas of the brain cause different types of animal behavioral changes are the ones that we are still going to be looking at today. Will we come back to Antonio Moniz? Probably not. But I wanted you to be aware that our ideas and the way that we think about things today might be looked at in about 20 years as something completely foreign, as something that you would say now is backward science. And all of you would laugh and say, wow, Moniz, actually, why would you remove pieces of the brain in the prefrontal cortex? At the time, that was considered to be the best practice. And so what we consider the best practice now may not be the best practice in a few years' time. So I'm going to go through a lot of different things today. So we talked about some of the different tragedies of the mind, and we're going to go back and revisit major depressive disorder, and we'll go through some of the biology of different ideas about major depression today, and we'll talk about some of the different theories related to major depression, both today, a little bit on Tuesday. I'm going to leave parts of Tuesday for a review for the Thursday midterm. I really would like you to do well. And I'm going to talk to you a little bit about some of the different animal models that are thought to represent major depressive disorder, and then I'll give you some things to think about as we revisit it after the midterm. So if we were to go in, I've told you that one of the biggest issues that we have in major depression, how do you know someone has major depression? How do you know someone is depressed? How do you know they're not just feeling sad? It might go away in a week or two. How do you know that someone is actually going through a really tough time? How do you know that their brain is in trouble? We have no way to know. However, in a small number of individuals, there are small but consistent increases in a marker. And it's not universal. We can't say definitively that this is a biomarker for depression. But the levels of glucocorticoids in some individuals seem to be consistently increased. Do you guys remember any glucocorticoids that we've spoken about in class? Because if you don't, you should go back and review it for Thursday, because you definitely will need to know that. Any glucocorticoids? We talked about it. We talked about one in particular. I'm worried about next Thursday, to be honest. Any? Yes. Cortisol. That's right. And in some individuals, the cortisol levels are consistently high. What does cortisol do? Or where have we learned about cortisol? The HPA axis involved in stress. So imagine you're feeling like you're consistently stressed out for long periods of time. Imagine that for 9 months to a year at a time. So in these individuals, these small and consistent increases in glucocorticoids might actually be really important in our understanding of this disorder. We can also recapitulate, get back an animal model. It's not a perfect model, but the original models based on those clinical observations was that if you went in and you injected in cortisol or other corticosteroids, these glucocorticoids that are involved in the stress response into animals, they actually exhibit many, but not all, of the signs and symptoms of major depression. So I told you that one of the things that happens in major depression is that you have changes in your psychomotor abilities. You either move too much or you don't move at all. And in those animals, when you inject in enough of this glucocorticoid or cortisol, they exhibit immobility. They stop moving around. Again, many individuals will exhibit depression as a lack of motivation to move. They also have a decreased responsiveness in an operant conditioning task related to motivation. They might have signs and symptoms of anhedonia, lack of pleasurable responses. All of these things kind of looking like depression. We know that in certain individuals, and remember, I'll remind you that one of the statistics that we talked about in the last lecture was that females are more affected than males. In females, especially after birth, this postpartum depression is found in about 15 to 20% of individuals after birth. Again, staying with the female preponderance of depression, at different times during the menstrual cycle, many individuals have reported anecdotally, and again followed up with different types of clinical studies, that depression often accompanies different times of the menstrual cycle as well. That age range that we talked about earlier, 15 to 44, that accompanies this sort of greatest risk of changes in hormones. So especially for females, from the beginning of the menstrual cycle or menarche all the way to menopause is usually somewhere in the range of somewhere in the early teens to the mid 50s or so. And so is there sort of a link there? And many individuals are really interested in the correlation, not necessarily causation, between the different features that they saw with depression. So with that, there was an idea, and one of the first ideas was when biologists went and examined this disorder, is there actually something that is hormonal in origin? Can we understand this through hormones? So certainly I presented in that last slide that glucocorticoids, which are part of your hormonal axis, and that for female hormones, there might be some sort of correlation between these. So is there actually a hormonal reason for major depressive disorder or MDD? In a small subset of individuals, maybe somewhere between 10 and 20% of individuals who go in and visit their MD or their family physician, who are then referred to a psychiatrist, for some individuals, about 10 to 20%, they actually might have a biological cause for their depression. They might have hypothyroidism. And it has nothing to do with a particular stressful life event or anything else. They just might not have enough of the thyroid hormone, which is why they develop all of the signs and symptoms of depression. And again, there is a role for things like nutrition as well as hormones in the diagnosis of things like depression. So is this related in some way to hormones? One of these disorders that involves hypothyroidism and is one of the major causes of depression is Hashimoto's thyroiditis. And in Hashimoto's, this is actually a chronic lymphocytic form of thyroiditis. It's an autoimmune disorder. And one of the things that happens in this autoimmune disorder is that if the thyroid gland gets destroyed by an autoimmune response. The antibodies basically go in and start destroying the different thyroid cells. As a result of that, you no longer can produce thyroid hormone, and you exhibit all of the signs and symptoms of having hypothyroidism. When you have hypothyroidism and you don't have the thyroid hormone, one of the first things that happens is you start feeling fatigue. Thyroid hormone helps your cells to metabolize glucose, and it helps your cellular metabolism. And as a result, these individuals, as soon as this reaches a critical threshold, will start to exhibit signs of fatigue as well as sluggishness. They will also be exhibiting other clinical signs related to thyroid. Your thyroid hormone is there to help you maintain your core basal metabolic rate at 37 degrees. And as a result, when that starts to decrease, you're often more sensitive to cold. Outside of the physiological responses that are shown here for you, including things like increased sensitivity to cold, or having a hoarse voice, or having dry skin, and a puffy face, as you can see in this individual here, other things that are cognitive are also accompanied by a decrease in this thyroid hormone, including having increased anxiety, including things where you have sleep disturbances. And again, both mental health disorders as well as neurodegenerative disorders now seem to have a common link in sleep disturbances. And again, in the last lecture, I mentioned that many individuals that have depression have changes in their weight. They might start losing weight, but most often they start gaining weight. And it has nothing to do with the medication that they're taking, but it has everything to do with the underlying disorder. And these individuals also exhibit the same thing. They will have changes in weight as well. This disease, by the way, also affects women more and is often accompanied by depression. And so if we put all of that together, in at least a small subset of individuals that have a biological cause, having low thyroid levels can indeed cause major depressive disorder. And this is one of the reasons why you should always go in. You should never self-diagnose. Always go in and visit your family physician, have a referral to a psychiatrist, because this can be treated fairly easily. You can actually replace your thyroid hormone, and the signs and symptoms physiologically as well as mentally or cognitively will be eliminated. So in terms of other hormones, there were other vegetative functions that were affected in MDD. And this gets back actually to one of those individuals, Hess, Dr. Hess, who had actually looked at stimulating parts of the hypothalamus. And when he started stimulating parts of the hypothalamus, one of the things that he found was that vegetative functions, things related to sleep cycles, things related to feeding behavior in the anterior part and the lateral part of the hypothalamus were affected in his animal models. And so if we go back and we start looking at some of these vegetative functions and we start thinking about it from a biological perspective, what other hormones might be involved and what other types of links might we be able to draw along with these vegetative functions like sleep, which again is affected in this disorder. So one of these hormones that has been, again, very heavily researched is cortisol. Cortisol has a function in sleep. When you go to sleep, your cortisol levels actually decrease. Okay? So overall, one of the things that as you're sleeping, your stress hormone, your cortisol levels are the lowest they are during the day. Now, two things. One, we don't know if this is the cause or the effect, but in many individuals with major depression, they have elevated levels of cortisol. So they might not be sleeping, which is why cortisol might be going up, or cortisol might actually be causing them not to sleep. And again, it's not really clear, but it is a vegetative function that is strongly correlated with elevated levels of cortisol. So if we go in, is there another disease state that we can use, just like we did with Hashimoto's thyroiditis and changes in thyroid levels? Can we go in and take a look at another state where we have an overproduction of cortisol? And one of those disease states that overproduces cortisol is known as Cushing's syndrome. And again, we're looking at some of the potential hormones that might be involved in this particular disorder. And in this disorder, one of the things that happens is that these glucocorticoids start to run rampant, and they start to produce too much of this cortisol. Their blood levels of cortisol are consistently elevated, There are a number of reasons for why this happens. It could be due to a change in ACTH. You can actually go back and check where in this HPA axis that, again, I think we've talked about this earlier in the course. Yes, no? You need to know that for Thursday. So make sure that you do. Make sure that you know from the beginning in the hypothalamus all the way down to the immune cells. And you should know the immune cells that get affected by all the different factors that get released from both the adrenal glands that are sitting on top of the kidneys, as well as from noradrenaline itself. You should be aware of all of the different immune cells that get affected, as well as what happens to those immune cells. What do they start to secrete in response to having been stimulated by cortisol, etc.? Do any of you remember, by the way? So you have increased cortisol levels. You're really stressed out. You're stressed out right now trying to remember what did we talk about way back then. And what happens to your monocytes? What happens to some of your other immune cells? What do they start to secrete? Yes. Cytokines, right? Things like interleukin 1, interleukin 6. Cytokines get released, and cytokines are pro-inflammatory, incredibly bad for your brain. So we'll go back and we'll talk about this, but in Cushing's syndrome, where you have a consistent increase in cortisol levels because of the disruption in the HPA axis, these individuals also have depression. So is there a link between having either too much, in this case cortisol levels, and we can back that up experimentally at least partially in some animal models, or having too little of hormones like thyroid hormone? Can we account for some of the biological causes that relate to depression? At least in part, we think we can. And again, in this particular case, relating back to Cushing syndrome, these are all of the signs and symptoms that are associated with Cushing syndrome. So again, if you complain of things related to depression, and you go in and you visit your family physician, and they can rule out things like Hashimoto's disease, and they can rule out other things. One of the things that they might want to do, specifically if there is a family history of these types of disorders, is to give you a dexamethasone test. You can go in and get your cortisol levels measured. Your cortisol levels are really, really high. That might be the reason why. You might just simply have been pulling all-nighters for the last week or so. Who knows, right? But if you're given a dose of dexamethasone, which blocks some of the receptors in the brain, the ACTH receptors in the brain, which prevents the release of cortisol, and your cortisol levels go back down, it's likely due to Cushing syndrome. So you can actually get tested for this. So again, it suggests that something involving the HPA axis that's involved in vegetative functions might be involved in depression. So in these individuals, for example, and again, you can see it affects females slightly more than it affects males. In these individuals, they will have emotional disturbances, similar to what we would see in major depressive disorder. They will have changes in weight or obesity that often accompanies this. They will have a very characteristic buffalo hump, especially toward the latter parts of the disorder. If you've had this undiagnosed for a while, you will have this accumulation of fat at the base of your neck. And again, changes in things like your skin, etc. So in this case, we have an overstimulation of the cortisol system. We have too much cortisol, cortisol not being really great for you. And one of the things that we know you can get treated for in this particular disorder is to have RU486. And we talked about this previously, right? You remember where we talked about it? I promise you we talked about it. It's like reverse Jeopardy. Any of you remember it all? Because it will be important. So we talked about this in relation to Sandy and Conboy's paper related to stress and spatial navigation. And if, for example, you stress out, you have a mild stressor on rats, you can affect their performance in a Morris water maze. And if you go back in and you block some of the some of the glucocorticoid receptors, that increased performance that they have spatially actually disappears. So mild stress, again, in that context, was a good thing to have. But that's a mild stress over a really short period of time. Acute stress is not so bad for you. It helps you in the short run. But if you have high cortisol levels for months at a time, years at a time, it's actually very deleterious. So you can go in and block using RU486, which is often used as an adjunct form of antidepressant medication therapy or ADM therapy in certain cases of depression, especially if these individuals have had this for a while and they become psychotic and they start having hallucinations and they become dangerous to themselves or other individuals. RU486 is also given to them in addition to some of the drugs that we'll talk about in a few moments. So this gets into one of the other theories. So one theory is that it's all due to a hormonal imbalance. And certainly we can talk about a biological subset of individuals that have changes in some of the different hormones. So if you rule out cortisol, you rule out thyroid, what's left? Well, there's still a large proportion of individuals that we simply can't account for biologically. So what sorts of things might be involved in their changes in mood? So the biggest theory that came out afterwards, around the same time actually, was a theory that you have a neurochemical imbalance. How many of you know this theory? Well, not many of you know this theory. So in depression, you have a decrease in neurotransmitter levels. You haven't heard this theory before? No? Brand new. Okay. Well, this will be interesting. In some individuals, if you were to go in and you were to do, in this case, it would be either a PET or a SPECT scan. In these individuals, you would see an overall decrease in different neurotransmitters like serotonin or different neurotransmitters like dopamine and different neurotransmitters like noradrenaline. This would be what you would see, the areas that are lighting up really well, the normal neurotransmitter levels. And in depressed individuals, this seems to decrease, at least through things like positron emission tomography or PET scanning, etc., with specific neurotransmitters. One of the key things that most of you will have originally learned, hopefully, in your first year psychology or your second year neuroscience classes is that there is a decrease in neurotransmitter levels that accompanies major depression and other types of psychiatric conditions. Some of that comes from experimental models involving animals, and I'll go through some of that with you. And in some instances, substance abusers where they continually ramp up the dopaminergic system, the noradrenergic system, they will fall into depression, and then when they're put into a PET scan, they will exhibit exactly this type of pattern. So they have depression, they've overused the monoamine system, and as a result, they fall into depression. But it becomes a little bit unclear when we start going through some of the data whether or not this is a perfect model. And this gets into some of the classic experiments that were done in the 1950s. So again, you have to keep in mind, Nobel Prizes are actually really important for a variety of reasons. One is really to stimulate the scientific endeavor. So remember the 1949 Nobel Prize in Physiology and Medicine, one of those went to Walter Hess. And he had published papers where you could stimulate different regions of the brain, the anterior hypothalamus, and change some of the vegetative functions. And he knew that it was related to that stimulation. So you stimulated the lateral hypothalamus, the animal starts eating more. So as a result of that Nobel Prize and the interest in developing electrophysiological models where you stimulate different areas of the brain, there was tremendous increases in our understanding of the neurochemicals that were involved in different brain regions in the 1950s. The 1950s are looked on as sort of the golden era of neuroscience. And in this golden era of neuroscience, this neurochemical imbalance theory started to come around. Now again, it's not just animal models, by the way. In the 1950s in Montreal, there is a neurosurgeon by the name of Wilder Penfeld who's doing the exact same thing in human brains that are undergoing different types of elective surgery for things like epilepsy. And when he is going in and he is stimulating different regions of the brain for neurosurgery, not the leucotomies or the lobotomies, but different types of surgeries related to epilepsy, and he's stimulating different areas of the brain. When he starts stimulating some areas of the brain related to dopaminergic pathways, and he's talking to these individuals while they're awake, he realizes that many of the pathways that he later helps to identify are involved in things like pleasurable activities. So he stimulates an area of the brain. He asks, how do you feel? Wow, this is great. This feels like the most amazing thing of all time. It feels better than sex. Please don't stop stimulating me there. So he knows that there are different areas of the brain that seem to be involved in pleasurable activities, and this again is the 1950s. In the 1950s, we also start developing new classes of drugs that weren't really around before. Again, in the 1950s, after the Second World War, we have a number of different drugs that have started to come out. And I'll talk about those in a few moments. One of these drugs was originally an anti-hypertensive drug. So you had high blood pressure. One of the drugs that was developed in the 1950s was used to lower your blood pressure. And when those individuals that had high blood pressure took reserpine, which depleted monoamines, and they knew from animal studies that monoamine levels would decrease, you would be able to take out the brain, you would be able to run the neurochemicals that were there, even in the 1950s, do a bioassay for it, and you knew that the levels of monoamines like noradrenaline decreased. And that was the purpose of this drug. In some individuals that were hypertensive and they took this drug and it was overdosed for them, so they had no really overt signs, they fell into depression, suggesting that somewhere there was a neurochemical imbalance related to a monoamine. So you lower monoamines in your whole brain, and one of the things that happens is you develop depression. So again, suggesting that neurochemicals might be involved. So we have a surgical pathway, a drug-related event, and other types of drugs were also thought to, again, show that these pathways might be involved. Do you guys know what iproniazid is? It's not originally a drug that was prescribed for any kind of mental health issue at all. If you're taking any kind of biology class, you know what iproniazid was originally used for. Any ideas at all? Any guesses? Imagine this is your Thursday multiple choice test. Any ideas? Kidney problem? Okay, at least it's a guess. Good guess. Wrong guess, but good guess. Anything else? Yes.
I'm cheating.
You're cheating. Okay. And when you're cheating, are you a good cheater or a bad cheater? Tuberculosis, right. So again, after World War II, there was lots of cases of tuberculosis, and in one instance, a drug, iproniazid, was developed for tuberculosis, which was rampant in the 1940s in the 1940s to 50s after World War II. And when those individuals that were given iproniazid to treat tuberculosis, they looked like they were happy. And so if you have a condition where someone looks sad all the time, and you have this drug that makes people look happier, why not give this drug iproniazid to people that look sad? And it was used as an antidepressant. It was used as an antidepressant up until about a decade ago in a lot of different countries, and it was stopped being used because it was very non-specific. Imipramine was sort of a first-generation tricyclic antidepressant, and they also showed very good responsiveness in psychiatric conditions. So they were shown to have good effects overall as antidepressants. Later, in the 1960s, these drugs and other classes of drugs were actually shown to increase or enhance the transmission of serotonin as well as noradrenaline. The original drugs, by the way, were not designed primarily to target serotonin nor noradrenaline. We think now that many of your monoamines are affected, including serotonin as well as noradrenaline, but originally we weren't really sure. It was just classified as a monoamine disorder. So again, is there some significance to some of these different findings? So if we were to take a look at one of those neurotransmitters, and we'll come back to some of the other ones later on in this course, if we were to look at one of those neurotransmitters, we've already looked at this particular structure earlier. the locus coeruleus. Do you remember the locus coeruleus at all? Yes, okay. So the locus coeruleus was mentioned in the Parkinson's lecture that we had a little while ago. And there are two major neuronal tracts that actually produce noradrenaline. So we don't have a huge number of neurons that actually make or synthesize and release noradrenaline. We have the locus coeruleus as well as the lateral tegmental group of neurons. And these different groups of neurons form the dorsal bundle as well as the medial forebrain bundle. There are many different neurons that use this medial forebrain bundle. Noradrenaline happens to be one of them. And dopamine is another one that uses this medial forebrain bundle. These neurons that project from the locus coeruleus as well as the lateral tegmental group of neurons actually project to many different areas in the brain. And when, for example, they send their projections out through the medial forebrain bundle and the dorsal bundle here, one of the things that happens is because of the circulation and the blood flow to this area of the brain, these are particularly vulnerable to things like stroke. And so this neurotransmitter has been implicated in you being alert, vigilant. If you're paying attention and you are listening to what's going on or you're hyper aware of things, noradrenaline is at work in different areas of your brain. So it's involved in things like vigilance as well as alertness. It's also been implicated indirectly, being involved in sleep-wake cycles as well, and it might be used to reinforce different types of reward-mediated behavior. Interestingly, if you had a stroke right here, right near the dorsal adrenergic bundle, and this happens more frequently than you would imagine, those individuals that have a stroke in this area of the brain actually exhibit some really interesting phenomena. One is they actually develop depression. It's very specific. They have a form of depression that can be diagnosed in a very particular way. And so this interesting phenomenon being they have depression. They don't really have any other motor disabilities because this area of the brain isn't really involved in sending any projections out to the supplementary or motor cortex or any of the SMA areas, but they do fall into depression. And that again suggests that maybe a disruption in this monoamine, in this case noradrenaline pathway, might be really important. So is the theory right? It's hard to say. There's some suggesting that this theory of using or decreasing different neurotransmitters is correct. And there's a lot of evidence also to suggest that this theory is completely erroneous. I'll take you through both because I don't want you to be students who are just blindly accepting whatever someone tells you. I want you to be thinking about, okay, this is sort of the evidence that backs up this theory, and this is the evidence that backs up another theory. And I want you to be aware of the different types of theories that are around there. However, based on all of the experiments, whether it's animal studies, whether it's clinical studies, whether it's anecdotal evidence, many of the different drug companies have actually started to produce different drugs that will enhance the level of neurotransmitter. Again, depression being thought simplistically as a decrease in the release of neurotransmitters in different groups of neurons, might be serotonin, might be noradrenaline, might be dopamine, might be any one of those monoamines. If there is not enough of this neurotransmitter, let's create drugs that can actually go in and block either the degradation of those neurotransmitters at the synaptic cleft or block their reuptake into the presynaptic elements. And the vast majority of drugs that we use to treat psychiatric conditions and major depressive disorder are exactly those types of drugs. So I mentioned imipramine being the very first class of what's now classically called the tricyclic antidepressants, or TCAs. And TCAs block the uptake of many of the monoamines. They're non-specific. They will block the uptake of noradrenaline, dopamine, serotonin, and many other drugs beside those. So these are sort of reuptake inhibitors. Monoamine oxidases are involved in the breakdown of any of the neurotransmitters. So some of these monoamine oxidases, or MAOs, are found in the synaptic cleft, and any neurotransmitter that gets in contact with this enzyme will be broken down. And as a result, if we stop the breakdown by inhibiting this MAO inhibitor, MAO, or monoamine oxidase enzyme found out in the synaptic cleft or found inside the neurons, it means that we have more neurotransmitter around for longer periods of time. The other classic approach is to block the uptake. So normally neurotransmitters are released and then they're taken back up. It's more efficient for your neurons to actually take up the neurotransmitter than to synthesize these things again. So if we block the reuptake into the presynaptic element, can we increase the level of neurotransmitters for longer periods of time out here in the synaptic cleft? And that certainly is a strategy that many drug companies have taken. So selective serotonin reuptake inhibitors, or SSRIs, things like Zoloft. Many of you will have heard of Zoloft. It was, for the very longest period of time, one of the best sellers. For Eli Lilly in 1987, the best sort of SSRI that was available was known as fluoxetine. And the latest class of these selective reuptake inhibitors include drugs like duoxetine, which inhibit both the reuptake of noradrenaline as well as serotonin. So when I, just out of curiosity, when I mention things like 5-HT receptors here, what is the neurotransmitter that interacts with 5-HT? Serotonin. Okay, great. Glad that you know. You had a question? So that's okay, I'll ask you to hold on to that. So by doing this, do you affect the neuron? It turns out that you do. We'll come back to that in, not sure if we're going to cover it on Tuesday, because I want to spend most of Tuesday getting you ready for the Thursday midterm, but we will come back to that. It's been a very controversial area. This theory sounds really good. We have animal models, we have human studies, we have areas where we have stroke in areas that affect noradrenaline, so it kind of looks right, but at the same time, it kind of looks wrong. And we'll get back to that, and it's a good question, actually. So if we block reuptake, what happens to these neurons presynaptically? What happens to their synthetic enzymes? What happens to their release mechanisms? And we'll get back to all of that a little bit later on. I like statistics. Do you guys like statistics? No? You guys should love statistics. Statistics are fun. Statistics are what drive neuroscience right now. This is actually a really funky looking slide. I want you to know this slide, not to memorize this slide, but to be aware of a couple of different things, because we'll come back to it at the very end of the course. How many of you have heard of population statistics? Okay, tell me what population statistics are. Okay, you've heard of them, but you're not really sure what population statistics are. Fine, I was the same. One of the things that you can do, and this has actually been reproduced, it was originally published in the International Journal of Neuropsychopharmacology back in 2011. And then we'll take a break after we go through this. There have been increased reports that when scientists and researchers go in and check the efficacy of these new classes of antidepressant medications, and they compare them to the pre-existing class. So I told you in 1987, the best drug that was available from Eli Lilly was fluoxetine, for example. And when they go back and they look at how good is this compared to the classic drug like fluoxetine that is now 20 years old, one of the things that they started to realize is that these antidepressant medications are actually now, in 2011, 2014, they're not as good as they were back in 1987. Why are they not as good as they were in 1987? So when you start looking at the usage of antidepressant medications in things like depression, as well as in bipolar disorder, these drugs don't look like they're as good. Why do you think that's the case? And this is what Hedges G is showing you. This Hedges G is this population statistic, and whether you're looking at it in two different ways, you can use it in either way. It doesn't matter. It's exactly the same thing. I know it drives students bonkers when I go through this, but it's either sites per trial. So in other words, I could be a drug company and I do like 20 different trials or 40 different trials or 60, or I could just be looking at this with time. So this could be 1980, this could be 1990, this could be the year 2000. It's just the more trials that I look at with this drug, the less effective it is. The fewer individuals that are getting the same responsiveness as those individuals out here at time zero. Let's say 1987. Why is that the case? Any ideas? You have an idea at the back? So we weren't as knowledgeable in 1987 about how different drugs work. But these are just looking at the effectiveness on patients. And it's the same drug that was used in 1987. It's the same drug now. So we still use fluoxetine. It's still prescribed for individuals. Why is the effectiveness going down? Are we mutating as a species? Yes, at the back. So one possibility is, and that's a good point, one possibility is the population that we're giving this drug to is changing, not because we're mutating as a species, but because the types of individuals that have depression, they're different than they were back then. At least in terms of the HMB scores, the Hamilton Rating Score for Depression with the PHQ-9 questionnaire, it doesn't look like we're any more severe in terms of depression than we were back in 1987. So depression is depression in 1987 in the year 2014. Good idea though. Anything else? Yes. So they don't actually have depression, therefore the drug isn't working as well on them. Have you ever taken an antidepressant med when you're not depressed? No? Have any of you done that? Okay, it's good. Never self-experiment. That's the one lesson that you should learn from this course. Nothing else. Never self-experiment. I did. When I wasn't depressed, I took some antidepressant meds just to see what it was like. Doesn't really do very much to you. So it won't make you like change your personality or anything else. Any other ideas? We'll take one last one. Yes. Increases habituation. They just might be getting more tolerant of the drug, potentially. However, that's not the case. How do drug companies measure the effectiveness of the drug? What do they do? How do they test whether drug A is good versus drug B? What do you do in a drug trial? Yes.
I think like inflators or retinol.
These are humans. We don't do that. Okay. Yes, at the back. You do a double blind. Okay. So what do you compare that drug that you want to? A placebo. And we don't understand this phenomenon, by the way, but it has been well reported. Over the last 30 years, the placebo effect in individuals has actually been going up. So the drugs are just as good as they were back in 1987. The drugs are actually, we have more drugs that are available. But overall, compared to their control counterparts, when we go in and look at each of these trials, the placebo effect has been going up. And we really don't understand why the placebo effect. So if I have depression and I am given a placebo, that placebo makes me feel better. And compared to the placebos that were given back in 1987, more people have this placebo effect now than back then. And so overall, when I'm looking at the placebo versus the drug effect, it looks like the drugs are becoming less and less efficacious. But it turns out that the placebo effect is getting more and more powerful, and we really have no idea why that's occurring. Okay, so if you don't mind, we'll take a quick break now. We'll come back at 10:10, and then we'll try to finish off the rest of the lecture. Yeah. It's fine. We're listening to it. Okay, so we won't be there. Sorry. You happen to be really punctual. There's no lab that you don't walk with.
Yeah, that's exactly why. I mean, the entorhinal cortex this summer we had like a big. I don't want to get it, but. So wait, I wanted to know your an idea of providing a mechanism. There's also in the paper, and I didn't know if this would be extra because I just thought to provide. You can. You don't need it per se, but I think that you can follow my so I know you're going to be doing some pathway study, and then you're doing some behavioral studies. Okay. I think they completely get the work with this, so that's the major focus. How would this offer you? Okay, thanks so much. Which is your you might want to fine with me. As long as you're comfortable with it's a Word doc. Yeah, it's a Word doc. Who knew we had so many artistic people? Very nice. No, you still need them. They not necessarily. So, for example, like a skirt, some groups of neurologically amygdala will actually show increase in something that's currently on the yeah, they're not always turned on. They turn on. They're immediately. Yeah, you have an implicated in shock and total very clearly CPOS activation or other genes on like phosphorylation or yes. It's not around. So rats have any placebo effect. Rats could care less if they're getting sugar or they're getting whatever. And in humans, the placebo effect is going to increase over time. And so when you compare it to, so let's say the level of responsiveness to individuals that have depression, getting a drug that addresses depression is high. And this is how I was talking about and compared to the placebo. So I'm depressed, I'm given a sugar pill, I'm reducing my overall mental health, my emotional status after the drug. And this is 1987. So in 2014, when I do the exact same thing, what happens is but now, the number of people that respond to placebo is not much like this. So when I compare the two results, it looks like it's going to responsiveness stays the same. It doesn't work. In rats don't absorb
No, actually, I think we got to go. So sorry.
Which home?
Hey, hi, folks. Can we catch up after?
Yeah, I just had to go back to another class.
Can we catch up after your class?
After the next class.
Yes. Okay, so lots of great questions. One thing I forgot to mention, which was actually somewhat important. There is a fundamental difference between depression as well as bipolar disorder. Even though in manic depression you fall into and out of these different types of moods, overall there actually is a difference between being in depression versus being in the down state of bipolar disorder. Why is that diagnosis important? One of the things that was found out almost by accident, and we'll get back to this when we come back after the break and after your midterm. If you have been misdiagnosed as having depression and you are actually bipolar and you are treated with a tricyclic antidepressant, you will actually speed up your mania. You'll actually be pushed into the manic phase, which is why now psychiatrists spend so much time trying to figure out if you have bipolar disorder or if you have major depressive disorder. And it is something very, very important to realize. Now we have this understanding that many of these different mental health issues are actually not really the same thing. Although there might be some commonalities, there are also a lot of different changes that are going on as well. So we'll get back to that after the break, but I wanted you to be aware of that. And when we come back after reading week, we'll talk a little bit more about that as well. All of these theories are really just theories. These antidepressant medications actually are not that effective. Again, I'm using the very conservative value of about 40 to 50%. Some individuals will say that antidepressants are only about 30% effective, and it only works on about a third of individuals. If that drug is so great, and we have so many different classes of drugs, why is it so low in terms of its efficacy? I'm not really asking a question.
I know.
You really want to say something? Go for it. Yes, please do.
But like, there is no form of therapy that is better than that.
There's no form of therapy that's better than that.
I'm even talking about CBT. Like,
Yep.
it doesn't work for everyone. So like, for you to say that that's like effective, that's not
That's okay. It's okay. You know, that first figure that I had up there was sort of a brain and the boxing glove. I don't want you to be in this class just to be brainwashed by me, although it'd be nice if all of you were brainwashed and all love neuroscience. That would be great. There is a fundamental reason, though, why we think, we're not sure, why the biology of this may not be as effective as we would like it to be. And again, you know, does taking Tylenol work on all of you in terms of getting rid of your headache? Not all of you, but for many of you it does. And so this is one of the goals for your generation, is to develop more effective therapies or to streamline therapies that make it more effective for you earlier. So the current thinking is that if this drug doesn't work after 3 to 4 weeks of trying it, you'll be put on another drug afterwards. And if that doesn't work, we'll put you on a third class of drugs. And if that doesn't work, well, maybe you have a treatment-resistant form of depression. Maybe you should be looking at other options that are available for you, some of which we'll be talking about a little bit later on. The interesting thing is, I don't like the biology of this disorder. The biology of this disorder looks really weird to me as a neurobiologist. So why are the monoamines affected, but not the GABAergic and glutamatergic neuron systems, right? It's affecting that many different areas of the brain. Your brain is shrinking. All of your neurons are being inundated with either different stress hormones or different types of cytokines. But overall, the GABA and glutamate neurotransmission, as far as most neurobiologists can determine, isn't affected at all. You'd expect that since 80% of all the neurons in your brain use glutamate as a neurotransmitter, that you should see some decrease, but you don't. So why is it so selective for these different monoamines? Again, something that we'll talk about a little bit later on. Again, when we go back and we take a look at that, there's a lot to suggest that maybe this monoamine hypothesis is maybe not as accurate as we thought that it was. If you go in and you take a antidepressant, and you take one of those different antidepressants, whether it's a tricyclic or whether you take a selected serotonin reuptake inhibitor, and you go back and you put someone in a PET scan, one of the things that you will see is that the levels of neurotransmitters actually are starting to become elevated within a few hours of administration. They won't feel any better though for weeks at a time to maybe a month at a time, somewhere between 3 and 4 weeks. So if it's really a decrease in neurotransmitters that causes depression and the neurotransmitter levels are going back up, why don't they feel better if this drug is working on neurotransmission until 3 to 4 weeks later? And again, it's one of those biologies that really is troubling, right? So not only is it certain groups of neurons, not all groups of neurons, not GABAergic, not glutamatergic. And again, neurotransmitter levels are being affected. Why is this the case? And why doesn't it fit in with this decrease in neurotransmitter levels in certain areas of the brain? So there are lots of things that are now coming out in the research. So for example, those of you who were checking things out online earlier in the week, you'll note that there was a massive study that was done, a meta-analysis, and we'll go through a meta-analysis when we come back from the break. There was a meta-analysis that actually looked at changes in brain structures in the insula, which isn't on this particular diagram, I don't think. They also examined the anterior cingulate in things like schizophrenia, major depression, bipolar disorder, and those seem to be now the hub that seems to set off these different types of disorders. In depression, though, your brain physically gets affected. So if you were to go in and you had an MRI done before and after depression, one of the things that is observed is that there is less gray matter. And again, gray matter meaning what? What's being affected? Cell bodies, the number of neurons. Also a reduced size of the white matter tracts. Again, the axons are being affected as well. Less glia, which is surprising that we're also affecting glia in different areas of the brain like the hippocampus as well as the prefrontal cortex. The anterior cingulate cortex also seems to be changed both in terms of activity. There's a resting level of activity that is higher in depressed individuals when compared to normal individuals that are not depressed, as well as the amygdala. Some indication that it's bigger, physically bigger in size, as well as being more active or hyperactive in depressed individuals as well. Some individuals have also reported that the left prefrontal cortex, which in some instances has been characterized as being involved in generating positive mood or modulating your positive mood, has a decreased activity as well as a decrease in size. We've already talked about the importance of this hypothalamic pituitary axis, and again, in some individuals, this also seems to be overly active. So I told you earlier on that one of the big issues that we have is that these drugs don't seem to be universally effective. And in some individuals, a small proportion of these individuals, you can go through and have, as Raquel mentioned earlier on, you could do cognitive behavioral therapy, you could do talk therapy, social therapy, whatever you want. You can put them on different forms of antidepressant medications, and they're not very effective in these treatment-resistant individuals. And these treatment-resistant individuals are very troubling because I mentioned in the last class that about 10 to 15% of individuals that have any form of depression, and we now realize depression is not a homogeneous disorder. There are probably many subtypes of depression, just like there are many subtypes of autism, many subtypes of different neurodegenerative conditions. And in these individuals, they seem to be more susceptible to having suicidal ideation. And one of the researchers that originally started her work here in Toronto, Helen Mayberg, before she moved down to the United States, one of the things that they realized is in these treatment-resistant individuals, that when you went in and examined an area of the subgenual cingulate cortex within the prefrontal cortex, and it's shown for you here, this area CG25, in depressed individuals, it has a sort of unique phenomenon, especially for those individuals that are more likely to go and have suicidal ideation. In these individuals who are chronically depressed, who are more likely to commit suicide, this area of the brain known as area CG25 seems to be hyperactive. It's always turned on. Now, why is area CG25 so important? Individuals like Helen Mayberg and others have shown that this area of the subgenual cingulate cortex is responsive to sad faces, for example. If you see someone who's sad, or you yourself are sad, this area of the brain lights up. But it's only when you see a sad face. If you see someone sad, you see someone crying, you see someone after their Chem 220 midterm, for example. When you see those individuals, this area of the brain lights up. But in treatment-resistant individuals, this area is always turned on. And so one of the things that Helen Mayberg and others pioneered was using deep brain stimulation to put in an electrode and to turn off or inactivate this area was found to be very effective in these treatment-resistant individuals that don't respond to pharmacology and don't respond to cognitive behavioral therapy. So are areas of the brain specifically involved? Yes, they are. And can we use other techniques besides antidepressant medications to treat this? It seems that we can. I'm going to segue a little bit because right now you are all being inundated with a whole bunch of different types of health and disease related news. Right? You have nothing further to do than to open up the newspaper or open up your browser today, and you will know that, for example, there's this great controversy about different types of vaccinations. So whether you should have measles vaccination or not, or whether you should have HPV vaccination or not. We are living in a society where viruses are all around us, and right now there is this great controversy related to vaccination. And I wanted to get into one interesting theory related to depression because we are interested in the biological cause for depression, and we're going to be examining this sort of as a test case for how we look at things in terms of biology. We don't really understand depression, to be quite honest. Why are some neurons affected and not others? Why are some monoamines affected and some are not? Why are some areas increasing in size? Why are some areas decreasing in size? How do we account for why person A, that stress causes them to fall into depression? Person B, who has much, much more stress in their life, never falls into depression. Why is that the case? Why can we not understand this age-old phenomenon from a biological perspective? And this is one of the things that Janice Clements was really interested in. When the Human Genome Project was initiated in 1990 by Bill Clinton, and again, much of the human genome had already started to have been mapped out before 1990, one of the things that individuals started to realize was that if you examined our genome, about 8% of our total genome actually contains remnants of these endogenous retroviruses or ERVs. So embedded within our human genome, we have a viral genome that is sitting on top of it. And it was really interesting that we have the endogenous retroviral genome. And when individuals like Janice Clements started to examine this, there were a lot of different types of viruses and retroviruses, things like HIV, for example. If you have ever encountered or been exposed to that, you might have different parts of HIV sitting in your genome, or hepatitis B gets incorporated into your genome. And we know, for example, that viruses affect not only our health, but can also affect our neurons. And again, it was thought for the very longest time that our brain was a protected organ. And it turns out that it's not. And I'm going to give you some evidence that it's not starting today. Can you give me any example, without going any further, about how viruses can infect neurons? Anything anecdotally that you can relate or tell me about? Any viruses that you know of that can actually infect neurons outside of HIV, outside of Hep B? Yes. So polio, certainly. Anything else that you're aware of? So the rabies virus, you might have heard of that. So a dog gets bitten, they exhibit changes in their behavior. So they get bitten in the periphery, that virus travels along nerves and eventually gets up into the brain. And again, we have many examples of that. How many of you have had chicken pox? And you actually had the chicken pox, that virus is still living inside of your cranial nerves, it's still living inside of your spinal nerves, and it's protected there. The virus loves living there because these antibodies can't really attack them as they're sitting there inside the nerves in different parts of your CNS. So in humans, one of the things that individuals have found is that there is a specific gene element known as a Borna-like N gene element that has been added to our DNA. So this Borna virus actually infects horses, and for some reason it's also been incorporated into our genome as well. And this Borna-like element, gene element, that has been added to our DNA actually has some really unique properties. So again, the Borna disease virus, or BDV, that has incorporated itself into our genome as that Borna N-like gene element, this is a neurotropic virus. The paper that I'm going to be presenting to you that was published in 2009 and that was followed up in 2012 actually is also a neurotropic virus. It turns out most viruses, like chickenpox, like the rabies virus, all endogenous retroviruses are neurotropic, which means that they can travel along nerves and infect the cell body. And this is another example of a the Borna disease virus, or BDV, is another neurotropic virus that can travel along nerves and infect the cell bodies. And it turns out most mammals are susceptible to this. In humans, as Janice Clement started to examine this back in the early 2000s, there was some suggestion that maybe one of the reasons why we can't understand why some individuals are affected versus others, even if we look at their genotype, and again, we'll get into genotyping later on, there's been some suggestion that different mood disorders and psychoses, schizophrenia, as well as depression, are caused by the remnants of this virus. And again, because these are viral elements, they have the ability to incorporate themselves into different regions of our DNA. So when she started to go back and she published this in a science paper earlier on, one of the things that she found was that in patients with mood disorders, one of the things that she was able to find are detectable levels of this phosphoprotein P24, which is part of the replication machinery of the Borna disease virus that's sitting in all of our human DNA right now. And she was able to isolate it from these individuals that had the mood disorder as the mood disorder erupted. So when they started exhibiting depression, she was able to find both the mRNA as well as the antibodies associated to P24 in the blood of these individuals as they started to undergo this mood disorder. And she didn't really find detectable levels in individuals that didn't have this mood disorder. So it's kind of an interesting hypothesis. It sort of sat on the shelf for a very long period of time. However, there's a lot of evidence to show that our bodies, our neurons, are very susceptible to viruses. Now, this is a little different. It has nothing to do with a mood disorder. This gets back into Parkinson's, and I just happen to really like the story, to be quite honest. We had sort of talked about Parkinson's a lot, and this gives you a slightly different view of what these different types of viruses actually can do, and how we as scientists can go about understanding how viruses infect neurons, because they do. We know that they're neurotropic. It's been known for a very long period of time that viruses infect neurons, and by infecting neurons, they potentially can be very deleterious. What happened in the year 1918? Yeah. So the influenza virus, this was also called what type of flu? The Spanish flu. The Spanish flu was running throughout the globe. It was killing somewhere between 20 and 50 million individuals worldwide. It was one of the worst pandemics that we've ever seen. This was caused by a virus known as H1N1. And the results, again, were devastating. It was thought for example, it's been estimated. No one can actually tell. We can't actually even tell how many people were actually affected and were killed by the Spanish flu. But it's been estimated that because it affected individuals that were between the ages of 15 to 34, these were the most susceptible individuals, and these were the individuals that died the most often with Spanish flu. It actually affected the global life expectancy by 10 years. It dropped. Like the global life expectancy, because it killed off so many young individuals, actually dropped. When individuals that were interested in what happened in 1918 using modern molecular techniques went and investigated the outbreak, one of the things that when they looked at survivors of the 1918 flu outbreak, as well as exhuming bodies that were associated with the 1918 flu outbreak, these individuals exhibited what is now classically called von Economo disease or encephalitis lethargica. They were slow to move. Okay? So you have a flu, you were infected with this virus, the H1N1 flu, Spanish flu virus, and you started to move slowly, especially as you got older. You exhibited classic signs of von Economo or encephalitis lethargica. You were slow to move. It sounds a lot like Parkinson's disease, in other words, where you have a slowness of movement, where you have a movement disorder, where you can't really move well. And again, there's been some evidence to suggest, and this was published back in 2011, that you can actually go in and isolate the influenza A virus in the human Parkinson's disease brain that might account for some of the things that happen following infection. And by the way, in a very small number of individuals, if you have the flu, you will exhibit these signs and symptoms. They will go away, by the way. They will disappear, but you will have, in these individuals, you will have encephalitis lethargica for brief periods of time. It still happens to this day. So I'm going to take you through a slightly different model. So I'm trying to make the case, and I'll come back to this, that our brains are susceptible and already have encoded within it different viral elements. So we have different parts of the viral genome within our genome, 8%, it's been estimated, and that different viruses can affect us, including like the H1N1 and others, can affect our neurons in a lot of different ways. It's been implicated in mood disorders, it's been implicated in Parkinson's. And I'm going to give you some more evidence that these neurotropic viruses, like H1N1, like the Borna disease virus and others, can really affect our neurons in profound ways and make the case that it will affect our neurons in terms of potentially the mood disorders that we'll get back to. So sticking with this theme of Parkinson's disease, right now, we're no longer as concerned about H1N1. A few years ago, we were all concerned about H5N1. You guys remember that? So H5N1, or the bird flu, was actually on everyone's mind. What if it mutates? What if H5N1 mutates enough and then it gets carried over so that it infects humans? And I don't know if you remember that or not, but it was a big concern at the time. People were keeping an eye out on Southeast Asia to see whether or not this bird flu would migrate and work its way into humans. This is actually right now the biggest pandemic threat that we have. If this thing does mutate, it's most likely going to be lethal. Why is it lethal? So if the 433 known cases, and we can't go and isolate all of them, of the 433 known human cases of H5N1 infection, 61% of those individuals die. So just to put the things in perspective, you see the Ebola outbreak right now, which is lethal. This is as lethal as Ebola. It's not the terrible consequences that you have with Ebola, but nevertheless, this has a high degree of lethality associated with it. This is a very pathogenic virus. Animal models that involve the H5N1 virus and infection with this virus also exhibit a number of acute neurological signs, ranging from encephalitis. So again, I'll draw your attention back to that von Economo's disease or the encephalitis lethargica. So they exhibit encephalitis as well as motor disturbances. They will eventually lose consciousness. And again, this is lethal for animals as well as it is for humans. So the longer term consequences. So let's say you are one of those lucky 39% that actually survive. Okay, so you don't die from having infection with H5N1. What happens to you if you happen to survive? What happened to those individuals that survived the Spanish flu epidemic back in 1918? So this was sort of the first paper that was published from this group. And actually, they followed up this paper in 2012 with the companion paper. Both were in relatively high impact journals. So it wasn't Bill's Journal of Neurophysiology and Witchcraft Flu. It was actually PNAS. So this is a well-established peer-reviewed journal. And it was one of the first papers that actually showed the long-lasting impact of having some sort of infectivity. In this particular case, I'm not going to talk about inflammation. You'll see inflammation in this course an awful lot. We've talked about it very briefly, and we'll come back to this many different times. And now the theory is that when you have inflammation, it actually is the beginning of this lifelong process of neurodegeneration. So it's never good for your brain to undergo inflammation at any point in time, whether it's traumatic brain injury, whether it is a mental health condition. It's never a good thing to have inflammation for long periods of time. So I'm going to take you through some of the results from this paper related to infectivity as well as neurodegeneration. And there are lots of things that I want you to make sure that you are aware of because I want you to be technically proficient in this. Not all of the details are all that important. I know there's a lot, but I want to take you through this particular paper. The experimental model is actually fairly robust. So this is a standard mouse model. The C57BL6J is used in most studies. It's a genetically well-defined mouse strain. And you can actually infect it with a non-lethal dose of the H5N1 virus without having it adapted for these mice. So they are equally infected with this particular strain. And this strain, I believe you'll see, is actually isolated from Southeast Asia, I believe from Vietnam. One of the things that the authors are really clear about showing, because it's always been very, very controversial, right? If you're going to infect a mouse, by the way, with a virus, how would you infect them with this virus? Injection, maybe. Do you get infected because someone sneaks up behind you and pulls out a little syringe and injects you with virus? Sometimes. Okay. I'm not sure who said that, but I don't want to hang out with that individual. Most of the time, you'll get it through one of your different membranes, right? So you'll get it exposed as an aerosolized form, and it gets in through your nasal membranes. You might touch your eye, etc. And so they wanted to make this as realistic as possible. And so they introduced this nasally, intranasally. So they injected the virus as a diluted form up into the nasal passage. And one of the things that they showed, which was actually really surprising, is that if you deliver a virus intranasally, this intranasal delivery is enough to have it travel from the peripheral nervous system into the central nervous system, as well as up into higher levels of the brain, including the parts of the basal ganglia. One of the other things that they were able to show that in regions that get affected or infected by the H5N1 virus, they also showed the activation of the microglia. You guys remember what the microglia are? Yes, that's that. They do respond to damage. And what else are they classically known as? Yeah, they are involved in cleaning and removing debris from dying cells. What else are they classically known as part of your nervous system? Yes. They are part of the immune response that your brain has, and these are the immune cells that might respond to inflammation, etc. So what they saw was that in these infected mice, in certain areas of the brain that were infected, they also saw activation of the resident immune cells of the brain known as the microglia. They also saw collections of alpha-synuclein that were being phosphorylated, and this started to aggregate. Remember, one of the signs that we look for in Parkinson's is the aggregation of this alpha-synuclein. And this actually persists after the infection has cleared up. That becomes important. So you've just recovered from having been infected with H5N1. You had bird flu. You weren't one of those 61% that died from this very lethal pathogenic virus. And now you think you're okay. You're okay because you're no longer coughing. You're no longer feeling bad. But your brain is actually still being infected. Your microglia are still activated. Your alpha-synuclein is starting to accumulate and misaggregate long after the infection itself has cleared. These animals, after they have cleared this infection, also start to exhibit a significant loss of those dopaminergic neurons in the substantia nigra parts, in fact, 60 days after the infection has been gone and cleared away. So they are indeed showing signs of loss of neurons through this alpha-synuclein pathway. So one of the things that this paper actually showed in a very elegant manner was that different types of these neurotropic viruses that travel along nerves can actually cause CNS disorders. So this again is that link. So here's a link between being infected with H5N1 and causing neurodegeneration. And so is it a large leap to suggest that maybe some of these other mental health disorders might in some way be related to the remnants of these viruses that exist in our genome from a long time ago? And again, we'll come back and revisit it. It's not universally accepted, but it is a very interesting hypothesis that fits some of the different criteria for this disorder. Now, there's a lot on the next two slides, and I'm going to take you through the ones that are the most important. You don't have to memorize everything that is here on the right. So how do you know that these neurons, the neurons are getting infected, infected? And again, you don't have to worry about recapitulating all of the data. I'm never going to be asking you to fill out any of these different types of things, but I'll take you through the most important things. How do I know that this virus is actually getting into neurons? So they have an antibody to this nucleoprotein. The nucleoprotein is part of H5N1. After they have infected nasally through the nose, the virus, they go back and they start staining different groups of neurons in the nervous system. And here is the enteric nervous system, the gut nervous system. And they start to see the presence peripherally of this nucleoprotein. Normally it's not found there, but these neurons in the gut have been infected after intranasal delivery 3 days afterwards, okay? And this travels up the nervous system, and this is what B and C are showing, that it gets up into the thoracic dorsal root ganglia. Again, the details are not important. They're staining for nucleoprotein, which is important. That's how you detect the virus and how it's being spread up. And by the third day after infection or post-infection, as shown here, the nucleoprotein is also found in the brainstem, okay? And this is believed to be one of the routes of entry into the CNS for different viruses. And again, this was the first study that actually suggested how viruses get into the brain from the periphery. You get exposed out here. It's not like you got injected here. It travels up through all of your different nerve systems. And where do you think it enters the brain? Any ideas? So where is sort of that interface between the brain and the peripheral nervous system? The spine, maybe? Where else? The cranial nerves. It turns out that the routes of entry for many of these viruses are actually up through the cranial nerves. And this, again, was one of the things that they had shown here. again, what else do they show here? Again, lots of different data, but one of the things that they show is that when they go back and they start looking for nucleoprotein, they see nucleoprotein, which shows that it's a virus, and it's only viral infection. You normally never have this in the brain, even at low levels if it's contained in your genome. They're actually showing that the nucleoprotein in green is detected in dopaminergic neurons in the substantia nigra. Okay, so they exhibit Parkinson's, and they're showing, as they should, that this nucleoprotein gets into the dopaminergic neurons in the substantia nigra. What do you think TH stands for here? So the red is actually all TH. What is TH? Yes? Tyrosine hydroxylase. This is one of the synthetic enzymes that's involved in dopaminergic production. So again, we don't need to worry about all of the different results that are shown here for you. But again, in H, they find that the nucleoprotein, and you don't need to worry about this, it's showing it's in the spinal cord, it's in a number of other neurons. But in H, one of the things that they're showing is that when they go in and they start staining the neuron, the nucleoprotein is found within the nucleus, exactly where you would think that it was found. So the other surprising thing, which I'll just show to you, it's found in microglia. So the nucleoprotein eventually gets in microglia, gets transported in axons, which is what is being shown in K and L. But interestingly, it gets excluded. This nucleoprotein, this virus, doesn't make its way into astrocytes. We don't really understand that either, right? So it's in these activated microglia, but it's not found in the astrocytes, which is what is being shown in J. So when you stain for the astrocytic marker GFAP, that we'll come back to several times in this course, they don't see it there. So why this virus is working the way that it is still kind of unknown. They addressed some of this in their follow-up companion paper in 2012. Do you have any questions about that before I go on? So just again to summarize a couple of things for you. So the most important things from this particular slide, we can see that neurons are infected by the detection of the nucleoprotein associated with the H5N1 virus. This H5N1 virus works its way into the substantia nigra neurons that we can see for the nucleoprotein as well as for tyrosine hydroxylase in the substantia nigra. It is found in the in the nucleus of the neurons that it infects, and it is found in the microglia, but it is not observed in astrocytes. And again, it's a really interesting phenomenon that way. If we were to go back and we were to take a look at what happens specifically in those different dopaminergic neurons, one of the things that we would see is that under normal conditions, when we start looking at the neurons, we don't see in these mice, we don't really see the accumulation of the phosphorylated version of this alpha-synuclein. So I don't know if you remember that lecture that we had last week, but one of the things that we looked at were certain clusters of families had a point mutation in alpha-synuclein. They overexpressed alpha-synuclein. In those individuals, we would also see a robust phosphorylation at serine 129 in alpha-synuclein. What this is showing is that in following infection, the nucleoprotein that you can see here works its way into the substantia nigra, and you also start to see the accumulation of the phosphoserine version of the alpha-synuclein. So this is the bad form. This is the form that will eventually cause misfolding, aggregation, and cell death. And again, if you continue all the way through this, you can actually see aggregation of alpha-synuclein here in panel C. So the alpha-synuclein does indeed start to aggregate, which suggests that these neurons are dying, and they die through a process of apoptosis. And we won't go through all of the other different panels. Again, some of this is related to activated microglia. So the take-home message from all of this being that your neurons are susceptible to viruses, and they can cause different types of neurodegenerative conditions, some of which is lethal, even if you're completely free of any of the signs and symptoms of having this particular infection, that it might have long-lasting consequences for you. So again, viral infection can produce a number of different cytokines. It can induce different cytokines like IL-1, IL-6, others as well, the GM-CSF, and we'll talk about all of these later on. And again, we don't see these in astrocytes. We're not really sure why that tends to be the case. And it turns out that the presence of these start off in the brainstem and eventually work their way up into the brain. So there's a route of entry, and it's a very potent route of entry as well. Okay, and again, we won't go into all of these details right now. We'll come back to them a little bit later on when we come back after the break, and we'll talk a little bit more about this alpha-synuclein. I'm going to jump to the last few slides related to this, and I will come back, I promise, to those particular slides. Our biggest issue right now is that, yes, we have these different models, and maybe we have a viral model that I'll go through very briefly with you when we come back. But we don't have a good animal model, which is what we're always looking for in biology. And right now, the best model that we have is this chronic unpredictable stress model. So it's a lot like the types of stress that you might be subjected to here at U of T or in your own lives, and we'll come back to that later. But we don't have a good model, and I want you to be aware of that all the way through. It's just like we saw with Parkinson's. We don't have a great model for Parkinson's. We have models for Parkinson's, but not necessarily great models. We don't have great models for depression either. And that is a real stumbling block for us as biologists, because we need to be able to manipulate this system. And if any of you can think of a really good model for developing an animal model of depression or any of these other mood disorders, you will be able to write your own ticket, because it is something that is really important right now in biology. And this gets into this last slide that I'll talk about today, which is related to this. We don't understand this disorder. So I gave you some of the biology today that we don't understand the disorder. We don't understand the genetics of this disorder either. So if you were to look within your own family, and someone in your family has had any kind of mental health disorder, whether it's schizophrenia, doesn't have to be depression, bipolar disorder, or anything else, that you are more likely to have an issue where you will develop major depression. So it kind of suggests, because there is a family history of mental health disorders, that depression might be linked to genetics. But in fact, it gets a little bit more complicated. If you look at identical twins, which theoretically should have identical genomes, it's not that it's 100%. If twin A gets depression, twin B is going to definitely get depression. It doesn't seem to work that way. They are at more risk, 50% more risk than the average population, but the genetics don't seem to indicate that it is a genetic disorder by itself. And so right now, this is the best case for where genetics and environment have to come together. And so this is the GXE model, genetics with environment, that we see this disorder coming to pass. So I'm going to leave this slide up there with you. How many of you, if you had to write the midterm on Tuesday, you'd be ready to go? And no one puts up their hand. Okay. You have a lot of things to do. So I saw some of your visual summaries. They look great. Please make sure that you're spending time doing that. It's due on Tuesday, so you have time to work on it. Should be more than enough time. However, there are other things that I want you to be able to do as well. Starting today, I'm going to ask you to start thinking about one of the questions that I'll be posting up there tonight. So I will be posting on the discussion board by about 8 o'clock tonight 5 different questions. You will be assigned one of the 5 different questions. This will help you get ready for the midterm next Thursday. It is also required as part of your participation mark. If you do it and you submit it back to me, you're going to get the participation mark. Okay? Like, I'm not going to even check your answer. I'll be posting it sort of anonymously on discussion board, but all I want to do is to see if you're doing. You can use your notes. I want you to use your notes to answer the question the best that you can. I want you to be able to post by Saturday at 12 noon. Okay? So you'll be submitting it to Dropbox by Saturday at 12 noon. It's about 5 or 6 sentences. Use your notes. Should be very involved. I want you to start studying. If you start studying now, you're going to be able to get an A. If you don't start studying now, you can still get an A, but it becomes more challenging for you to do so. My job is to make sure that all of you get at least an A. And I want you to be able to do that. Eventually, you're going to be posting, I will post anonymously all of your responses by question number. So let's do this sort of by random draw. Okay, so let's see. Maybe Marina, give me a number between 1 and 5. 3. So Marina will start at 3, and everyone under 8 will be like 4, 5, and we'll repeat back. So just to make this sort of a random thing, you will be assigned, Marina, for example, will be assigned question 3 to write her response to, and she will give feedback to question 4 that I'll be posting on the discussion board from one of her colleagues. By simply doing that, she's going to get 1% of her final mark. I'm not even going to look at the quality of the answer. Hopefully it's really good, but it's more to get you to get going. I want this class average to be about an A, to be honest. I'm hoping that it's going to be about an A because that means that I don't have to make the final exam cumulative, right? And that was our original goal. If it's at least an 80 average, no cumulative final exam. You guys can do that as a class, right? No? Okay. Yes, you will. You will do this as a class. You will have a class average of at least an 80. So be aware of these upcoming deadlines. Be aware that you have something due by Tuesday. Make sure that you're planning out your weekend. Make sure that you're studying. And I'll try to help you as much as possible.
Dr. Jeff, I was just wondering if I was tackling this graph report. I don't know if this is a problem.
Yes, as long as you have a brief explanation.
A brief explanation of it. Okay.
Good.
You need to have a quick look at this because I did it like just the type of this handwritten.
Okay.
Yeah, I just shall I scan it or because I now took a photo of it and then I just made it a PDF.
Okay. I would say
What is it better?
all of these are going to eventually be posted together as sort of an online book. So if you want that to go on as part of your visual summary, you can.
Yeah.
But everyone's going to be looking at it, so maybe you might want to do it graphically on the computer. Just make it a little bit if you have the time.
Yeah, sure. I can do that.
But in terms of the content, there is fine.
Okay. Okay. Thank you.
Yep. Yes. Let me just get out of this because I think we're still recording. But I'm not sure.